So yes, as Martin said, I'm going to talk about the origins of the workshop series. So Janet Treasure, who's at the Institute of Psychiatry in London, has worked for many years, obviously with eating disorders. She's a prolific researcher, publishes about 35 to 40 articles a year across a broad range of areas. And she's been particularly interested in the experience of carers for the last few years. And as a result of this, the initial work was looking at what are the factors that determine carer burden for eating disorders. So the work that she was doing in that led then to trying to model what the factors were, and from that research led to this idea of what can we do to perhaps intervene. So the 6-session collaborative care skills workshops have emanated out of that research that she has done. So just to sort of show you this is basically the model that she developed that from the research, saying these are the factors that seem to impact on carer burden and distress. This is that sort of outcome. So there's coping with the caring role, and the research showed that there were a number of factors that had a role to play. Now, many of these you'd probably be aware of. For example, one of the things that carers will often talk about is about unmet needs for information about how best to work within that caring role. And they'll often talk about having gone to GPs and GPs saying, oh, I don't really sort of know much about eating disorders, I've not seen them before, etc. like that. So really feeling sort of at a loss. And of course, that's the experience with EDV and the carers lines there, that carers are often coming sort of saying we're desperate for information, and so the services that are available at EDV certainly sort of fill that need. So unmet needs obviously is a very important sort of one there. Another one that you're probably very aware of would be these two things up here. The eating disorder behaviours themselves, having to tackle those things like the refusal to eat, or in cases of bulimia, binging and vomiting, as well as perhaps for many of the individuals this unwillingness to accept that they actually have a problem with their eating or their low weight, etc. So these are all sources of stress. But there are other ones as well that Janet's group identified. And these were things, for example, like including the interpersonal relationships between the carer and the individual, the way that they were relating, particularly when there were high levels of expressed emotion happening. So high levels of criticism and hostility, or high levels of emotional over-involvement and protectiveness going on. And also things like accommodating to the symptoms. So cleaning up after the person if they'd been binging and vomiting, or going out in the middle of the night to buy that one brand of yogurt that they'll eat in order to get them to eat. So there's a lot of that accommodation enabling, turning blind eye to some of the things, stopping people from coming around to the house and so on. And so all these factors seem to contribute to this experience of burden and distress. So the collaborative care workshops have really been designed to try and alter this by targeting each of these things. It recognises, for example, that perhaps if there are these problems with interpersonal relationships, we need to teach them communication skills. If there are problems with this accommodating to the symptoms, we have to teach people how to analyse what are the triggers to the problematic behaviours and how my responses might influence keeping them going, for example. So there's psychoeducation as well. And there's also about teaching them skills of motivational interviewing to perhaps push them along, push the person with the eating disorder along to be more willing to consider the possibility of change. So the workshops were designed to improve carers' well-being and distress, as well as improve their coping strategies, so some self-care strategies, teaching them to be sort of more emotionally intelligent about what was going on in the situation, and their problem-solving skills as well. But they're also designed to, as I said, try and alter some of these ineffective communication patterns that are going on, to educate them about the role of high expressed emotion in that, and understanding the process of change, so that stage of change model, the trans-theoretical model, and equip them with some basic skills in motivational interviewing. Now, I should just sort of say that the the collaborative care workshops are one way of delivering this material, and there are alternate ways of delivering it. It can be delivered on a one-to-one sort of basis using a worker who works with the person in conjunction with the self-help book and DVDs, for example, that they've developed. So this is another model of delivery. It's a telephone coaching model, and we did a little study a few years ago with EDV and some of the telephone counsellors and trained them up in doing this session. We did this with about 20 people over that time, and we have found that sort of worked pretty well as well. And there have been other ways that it's been modified to an online version and so on like that. So this is just one model of delivery that works well, but of course for other areas like regional areas where there might be too few people to form a group, there are these other models that you can work with. Okay, so the workshops are widely disseminated through the UK. So BEAT, for example, is the lead organisation there, probably pretty much akin to EDV, and they've taken on that role at the moment of training and disseminating the workshops and some of the other methods. And 3 studies have demonstrated its effectiveness there. First of all, there was a small sample that looked at just what was the effect on those key things, and it found sort of that it did reduce burden, did reduce distress, and the perceived impact of the eating disorder on this group of carers. Then there was a slightly larger study with 45 carers, found that it led to reductions in expressed emotion, so that high hostility, high levels of criticism and emotional over-involvement. And that was quite nice study as well. And more recently there was a qualitative study, and this was on adults, carers of adults inpatients with anorexia, and the participants, the carer participants, reported decreased caregiver burden. So you'll notice that all of those studies so far have focused on carer and outcomes on carers, which of course is the primary focus there. One of the things we don't know at this point in time is, of course, what the impact is on the actual person with the eating disorder. We know from some qualitative research that they sometimes have mixed feelings about their carers participating in this. So there'll be some very positive things, like they sort of say that carers are listening to them now, they feel that they're being better understood, that they're working together more collaboratively, which is great. But we also have some individuals who say they're just starting to talk like my psychologist, which I suppose is a good sign, because it means we're introducing that motivational interviewing sort of skills, and the parents are actually using it at home. So there's been some mixed things with regard to how the actual people with the eating disorder respond to it. So the way the workshops work, as we said, they're designed to address carer burden and distress through provision of practical support and guidance to the carers. So this is different from a traditional support group, which is unstructured in nature and just basically generally supportive, providing information. This is very much skill building, so it has a structured process to it. People are attending, and there are particular topics that are covered. There's exercises, there's some didactic presentations by the facilitators, but there's lots of exercises, structured discussion as part of those exercises, practice things that we do with them, and sending them away with homework. So there are set homework tasks as well. So the 6 2-hour workshops, 2 and a bit hours, because you've got to allow a little bit of a break. They cover things like motivation interviewing, readiness for change, about shaping and reinforcing non-eating disordered behaviour, and altering those high expressed emotion and other maladaptive communication patterns. And one of the underpinning ideas is that the carers model these skills through their interactions with the person with the eating disorder. So they learn the skills, and then they model those skills through the things. So they get better at expressing how they're feeling, for example, communicating that better. And hopefully by utilising these things, they show the person to take better care of themselves and to communicate more effectively back to their carers by creating that environment, but also modelling the skills. And a key part of that is because the facilitators in the group model the skills to the carers. So it's not just a didactic presentation. So the facilitators will use motivational interviewing skills in the delivery of the material. So we'll use this with the carers, and then we teach the carers in some ways to then apply this to the person with the eating disorder. So the type of content, as I said, 6 things. Firstly, we want to try and change so they're maladaptive interpersonal behaviours with the eating disorders. And we want to get them to try and reflect on their own responses and coping mechanisms to stressful situations, and create an understanding of that carer coping model, and look at how their predominant carer style is. And we use these animal analogies that Janet's group has developed. So these reflect different types of styles. So for example, high expressed emotion, that critical comments and hostility, reflected by that rhino trying to rush in and knock the problem over. So it's simple, all you have to do is eat, so they're charging at the problem. And if we compare that with the kangaroo who wants to put them back in the pouch, which is that emotional over-involvement type of style. Or those who might be very visibly anxious and all distressed, which is sort of this jellyfish, so that all their emotions are on display. Or perhaps an ostrich whose head's in the sand, just can't deal with the things. And we try to, and a terrier who's always at them, like barking at them, chip, 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 like that. We want to move them away from that style to the guiding dolphin who might guide and support and buoy you up, and the St. Bernard who is sitting there patiently waiting, willing to offer assistance when needed, but is calm and steady and quiet, doesn't go barking around and cause an avalanche of things. So these are the sort of styles that we sort of try to encourage the people to reflect on, what is my predominant style, and how we might benefit from moving more to the dolphin or the St. Bernard style. Week 2, we try to give them some understanding about how an eating disorder might affect brains and information processing, and also help them understand that maybe there are some characteristic styles that the person has with an eating disorder that may have even existed before they had the eating disorder, that they may have been, for example, quite rigid, not very good at being flexibility, very details focused as well, and helping them work out whether maybe what role this plays in the eating disorder, but whether they as a carer also may show some of those same attributes themselves, and this might impact on the way they respond to the eating disorder. So it's linking it in with that. And then we try to introduce this idea of emotional intelligence, being able to be reflective about what I'm feeling and what the other person might be feeling and how that's going to impact on the interaction, and beginning to step back a little bit rather than moving into their typical maladaptive sort of mode. Week 3, we introduced this idea of expressed emotion, about maintenance factors, things that might keep the eating disorder going. And one of the things we know about from the research is that expressed emotion in families is a maintaining factor. So it increases carer burden and distress, but it also maintains the eating disorder as well. And we introduced them to that model of change, that health behaviour change model, so the trans-theoretical stages of change model. It's helping them understand where the person might be sitting and getting them to reflect on that maybe they're in that pre-contemplation stage where they don't think that there's a problem, or maybe they're weighing up the pros and cons, so they're in contemplation, and helping them understand that perhaps they'll need to do different things depending on where they're at. Week 4 is really about where we're looking at motivational interviewing and other more adaptive things. So we have little phrases like view, very important encouraging words. So teaching them to sort of be able to compliment when they see the non-eating disordered behaviour. And then basically running them through the benefits of reflective listening and solution-focused questioning techniques, some of those principles that underpin motivation interviewing. So teaching them OARs for those people who know motivation interviewing. So open-ended questions, affirmations, reflective listening and summaries. And we get them to practice it and set them homework obviously on this as well. The next week we're sort of getting them more of a continuation, some of the more advanced sort of techniques and further practice, and then we're sort of moving them into beginning to understand the ABC, the antecedents, the behaviours and consequences, that functional analysis model for some of the problem sort of behaviours that they encounter, and try to work with them to begin to give them some practical knowledge about how they can apply it in their situations. And lastly, we look at tackling problem behaviours and working in this maintenance phase when people are sort of moving in, feeling things are going reasonably well, how we can continue going. Things. So common difficult behaviours, they might be binging, but they might also be things like continually asking the same sort of questions, more those obsessive types of reassurance seeking, etc. Or they might also be sometimes tantrum type of behaviour, so anger outbursts. So how we can work with those and just giving them more skills in that area, understanding from that ABC model, but also how might you use your motivation interviewing skills there as well. Okay, so as we said, 3 research studies in the UK seem to demonstrate sort of its effectiveness, but this was all conducted by the group who had developed the approach. So what we were interested in is if we move it out of that specific context, away from the UK and away from that team, can people who have attended workshops on the workshops, if you like, so been trained on it to a degree and done the reading, for example, can they have acquired the skills so they can apply them with equal effectiveness? So that's one of the sort of issues that we've been looking at. So is this where I get Geneviève to come up and tell us about this? No? I'll talk a little bit more. Yes, I can do that then. That's good. So what we did is Geneviève and I both had experience, long-term experience in running traditional carer support groups. Myself in Geelong, Geneviève in Canada. So we were both working at Deakin, and we came together to talk about, our interest and our experience in this. And what we were interested in was, can we apply the experience and knowledge from the UK to an Australian sample of people? So we looked at sort of, could we get a grant to try and do this? And so we did in late 2008. We got a small grant from Deakin Uni to pilot this. We went and did the training with Janet up in Byron Bay and communicated with her, read some more. She sent us some more material that helped guide what we were going to do. And so that first study in late 2008 with a small sample, 15 carers, seemed to show some promising results. And as a result of that, we commenced our collaboration with the EDV, and Rebecca will talk about that, from 2009 onwards. So we started running groups in conjunction with the workers there.
Russell, just in the origins of the work in the Treasure Group, how did the development of this work sort of sit alongside or relate to the work in the ward and, the clinical work, the sort of straightened work with client population?
Yes, because of course a lot of the work that they'd been doing was really in that work. And I suppose where it originated from was, it was an article that Janet wrote in an original sort of thing. They'd been applying motivation interviewing type techniques with people with eating disorders using the workers. So they developed an approach they called motivational enhancement training, which is basically motivation interviewing with a few other things are selected around that. Now they had written about that approach and seemed to work well, but they were recognising, of course, the difficulty that you had is if you didn't have the person there with you already, you were missing that opportunity to be able to really start doing some of the groundwork. So they started thinking about an approach that had been used in the US with people with substance-related problems about getting carers involved, and that perhaps carers could begin to do some of the groundwork. And this is a model developed by Miller. I can't remember what his first name was. And that model sort of then was the genesis for this. So it was really taking, we think that these things work when we're working as workers with the people in an inpatient setting or even outpatient setting. But what we're interested in is maybe we can get the families doing this. This is really sort of even better, because then we'll be working collaboratively together. So that's really sort of where the origins of it came from. So it was and I think the other thing dovetailing into it, as I said, was recognising the extent of carer burden and distress, and the model that showed these seem to be the factors, and recognising, hey, yeah, motivation interviewing and these other things actually fit into here?
Just a word on what happens in between the workshops in terms of homework, and in reference to the manual which is due to be released to facilitate.
Yes. So there are set sort of handouts, so that there are basically two types of homework. Some of that homework is about reading, so it's an information giving them additional information of what's covered in the actual session. So we might sort of say, well, we've covered this, here's some more information about this. So we talked about the health model, that trans-theoretical model. So we spend some time in the session talking about that, but then we'll give them handouts that explain it a little bit more. So they've got that chance to reflect. We give them, of course, copies of the slides that we show in the sessions as well. But we'll then sort of set them some homework. So one of the homework exercises, for example, to just give you an example, when we've talked about readiness to change, we set them a homework exercise to go home and have a conversation about readiness to change using readiness rulers on about how important they feel as a carer that they want the person to change, how confident they are, but then also sitting down and having a structured conversation with the person about how important they see to change and how confident they are of change. So they've got some set questions that they ask as a result of that as well, which is really quite a useful thing. And I think that that's a good example of the things. But we also ask them to do things that are specifically for themselves. So there might be set some tasks when we talk about self-care to think about what have you stopped doing that you used to do. And one of the people in the group we're currently running, she talked about walking the dogs. She used to love walking the dogs, and she hasn't been doing this because, of course, she doesn't want to involve exercise with her daughter. And so we're sort of thinking, well, okay, well, if you're not doing that, and you may have some logic to that, what else can you do that's going to replace that activity? Or we're getting them to try and re-engage with friends, for example, for their own sake, rather than sort of letting go of those things. So some of those things are quite practical. Some of them are really very focused on changing their interactions in the home. So yes, as Martin said, I'm going to talk about the origins of the workshop series. So Janet Treasure, who's at the Institute of Psychiatry in London, has worked for many years, obviously with eating disorders. She's a prolific researcher, publishes about 35 to 40 articles a year across a broad range of areas. And she's been particularly interested in the experience of carers for the last few years. And as a result of this, the initial work was looking at what are the factors that determine carer burden for eating disorders. So the work that she was doing in that led then to one there. Another one that you're probably very aware of would be these two things up here. The eating disorder behaviours themselves, having to tackle those things like the refusal to eat, or in cases of bulimia, binging and vomiting, as well as perhaps for many of the individuals, this unwillingness to accept that they actually have a problem with their eating or their low weight, etc. So these are all sources of stress. But there are other ones as well that Janet's group identified. And these were things, for example, like including the interpersonal relationships between the carer and the individual, the way that they're relating, particularly be aware of. For example, one of the things that carers will often talk about is about unmet needs for information about how best to work within that caring role. And they'll often talk about having gone to GPs and GPs saying, oh, I don't really sort of know much about eating disorders, I've not seen them before, etc. like that. So really feeling sort of at a loss. And of course, that's the experience with EDV and the carers lines there, that carers are often coming sort of saying we're desperate for information. And so the services that are available at EDV certainly sort of fill that need. So unmet needs obviously is a very important sort of trying to model what the factors were, and from that research led to this idea of what can we do to perhaps intervene. So the 6-session collaborative care skills workshops have emanated out of that research that she has done. So just to sort of show you this is basically the model that she developed from the research, saying these are the factors that seem to impact on carer burden and distress. This is that sort of outcome. So there's coping with the caring role. And the research showed that there were a number of factors that had a role to play. Now, many of these you'd probably be when there were high levels of expressed emotion happening, so high levels of criticism and hostility, or high levels of emotional over-involvement and protectiveness going on. And also things like accommodating to the symptoms. So cleaning up after the person if they'd been binging and vomiting, or going out in the middle of the night to buy that one brand of yogurt that they'll eat in order to get them to eat. So there's a lot of that accommodation and enabling, turning blind eye to some of the things, stopping people from coming around the house and so on. And so all these factors seem to contribute to